Thank you for the introduction. So, this is a case report that I wrote on an autoimmune disease called pityriasis lichenoides after a COVID-19 vaccination. So, let's get started. All right, so here, let me move this. So, pityriasis lichenoides is a rare autoimmune skin disease that presents as a spectrum of about 3 different disorders. So, we have pityriasis lichenoides veriformis acuta, or PLEVA, and we have pityriasis lichenoides chronica. That's the chronic form. And then we have febro-ulceronecrotic Mucher-Haberman's disease. And that's a severe form of things like fever, joint pain, and enlarged lymph nodes. Now, I'm just going to call it PLEVA from now on. Presents as crops of asymptomatic red oval-shaped papules on the trunk, upper extremities, and buttocks. And lesions can heal with various forms of scarring and hypo and hyperpigmentation. So the exact cause is unknown, but there's many hypotheses for the causes. One is a hypersensitivity reaction to an infection, like a virus, bacteria, or parasite, and another is an inflammatory reaction to a vaccination. So keep that in mind for this case, the inflammatory reaction, keep that in mind. And there have been multiple case reports of PLEVA following the top 3 COVID-19 vaccinations. Right. So it commonly affects children and young adults in their 30s with a slight male predominance. And it can mimic other skin diseases like arthropod bite reactions, varicella, and psoriasis. And keep the arthropod bite reactions, keep that in mind for this case, because that's pretty relevant later on, you'll see. So the diagnosis is clinical and can be confirmed with a skin biopsy. And a dermoscope can also be used to diagnose the condition as well. Now, a skin biopsy will show a superficial lymphocytic infiltrate. All right, that's just white blood cells in the skin. Parakeratoses, okay, papillary edema, and vesicular alteration of the basal layer. And we'll go over the histology of that in the next few slides, just so it's clear. All right, so this is normal skin, okay? And this is the epidermis, and this is the dermis, okay? And I just want to draw your attention here to the dermal papillae, which are these long, thin projections here, okay? And the dermal epidermal junction. Now, this is a close-up of the epidermis, okay? So we have the sternum corneum here, the sternum luteum, sternum granulosum, sternum spinosum, and the sternum basalis. And that's where the stem cells are. And again, you can see here the little dermal papillae, these long, thin projections here, and then here's a little keratinocyte right here. And then we also have a little basal cell, and that's where the stem cells are in the skin. Okay, so with normal skin, the keratinocytes lose their nuclei by the time they get to the top layer of skin. Okay, so as you can see here, all these keratinocytes, they don't have any nuclei. Okay, now with PLEVA, we have what's known as parakeratoses. So that's retained nuclei in the top layer of the skin, which is what we see, right? So right here, you can see these little arrows. These are the retained nuclei right here. Okay, so again, normal skin, no nuclei, PLEVA, retained nuclei. So again, we have normal skin. You can see here, there's no white blood cells. There are no red blood cells, right? Now with PLEVA, we have a lymphocytic infiltrate. And that's basically just white blood cells in the skin, right? And so you can see here all the little white blood cells all throughout here in kind of a band-like pattern, right? And then we'll also see red blood cells. That's what makes the papule red. And as you can see here, kind of the little red blood cells right around here. All right, so with normal skin, all right, I just want to draw your attention here to the dermal papillae. And what you're going to see are these long, thin projections, right? Right here, they're kind of long and they're thin, right? That's normal dermal papillae. Now with pleva, we're going to see papillary edema. So the dermal papillae are thick, they're edematous. You can even see white blood cells that are entering the dermal papillae here. So that's what we're going to see with pleva on histology. All right. So another thing that we'll see is what's called vesicular alteration of the basal layer. Okay. So the basal layer is right here, so you can see, right? And that's where the stem cells are. And these little white circles here, those are vacuoles. So what we're going to basically see are just vacuoles in the basal layer. And I actually had to look at several histology slides before I could see this. So, I mean, if you're, and then I had to draw the little arrows here. So it takes a little bit of, pattern recognition before you can kind of see it. So another thing that we'll see is keratinocyte necrosis. Okay, so here we go. So this is a normal keratinocyte right here. And as you can see, this is a necrotic keratinocyte here. Now, if you remember from MOD, the hallmark of necrosis is an eosinophilic cytoplasm. And that's what we see right here. All right. So the treatment is with erythromycin or doxycycline, which are used for their anti-inflammatory properties. And phototherapy with UV light has also been helpful. Now, methotrexate can be used for refractory symptoms. And it's very interesting because I was watching a YouTube video on a dermatologist that was explaining pleva, and someone in the comments wrote how apparently this person had been suffering the disease for many years, and this person didn't really even get any relief until they were started on methotrexate. So I thought that was kind of interesting. I mean, it was just a comment, in the YouTube video, but I thought that was interesting. Just thought I'd bring it up. All right. So this is the case. So we have a 32-year-old male that presents to a local urgent care clinic with about 50 to 100 non-paretic oval-shaped papules on his trunk, upper and lower extremities. And the patient reports he's had these spots for about a month. He's had no fever, no chills, and no joint pain. So as you can see here are the lesions here, and then here are the lesions here as well, kind of oval-shaped and red. And here are the lesions on one of his arm, again, kind of oval-shaped, red, right here. Look, you can even see some hypopigmentation from one of the lesions here. Right. The nurse practitioner at the urgent care diagnosed him with scabies and prescribed him with permethrin cream, which did not resolve the rash. In fact, the rash got worse. The patient also had his apartment fumigated multiple times. Due to lack of symptom relief, the patient made an appointment with a local dermatologist. And, I mean, if I saw this, someone came to me and said, "Hey, look at this." I would think that this looks like, bug bites, scabies, or bed bugs. That's what I would think. These look like bite reactions to me. So, I mean, I could totally understand why they would come up with that diagnosis. All right. So after examining him, the dermatologist diagnosed him with pleva. That's a terrible name. Someone should rename these things. Anyway, and one of the lesions was biopsied to confirm the diagnosis. The patient reports never having a rash like this before. However, he did receive his COVID-19 vaccination 10 days prior to the onset of the rash. So that's very interesting. So here you can see here are some more pictures of his leg. You can see the lesions right here. And here's a kind of more, you see with more light, you can see kind of the oval-shaped red lesions here. I mean, again, I wouldn't even know that this was, what this was if you hadn't told me. All right. So this is a copy of the patient's path report. Okay, and so we'll just see, as you can see here, we see vesicular alteration of the basal layer. That's what we saw before with those little kind of white circles in the basal layer, right? And then we have keratin necrosis, right? Uh, the lymphocytic infiltrate, right? Those are the white blood cells all throughout the skin. We have the dermal edema, and remember that's thick edematous dermal papillae that we would see. And then we have red blood cells. That's what makes the papule red. Now, so the results of the biopsy confirmed the diagnosis, and the patient was started on a 1 week dose of azithromycin, again for its anti-inflammatory properties. Unfortunately, there was no resolution of the rash with the antibiotic treatment. The dermatologist then informed him it would take months for the rash to kind of just go away on its own. And the patient did report a resolution of the rash in about a 6-month follow-up. Wow, 6 months. That's a very long time. 6 months? That's like half a year. That's a really long time to live with a rash like that. So, pleva can mimic many other common skin diseases and can be misdiagnosed. And this can create a great deal of emotional and psychological distress for the patient and their family members due to lack of symptom relief. In this case, the patient was diagnosed with scabies. He had his apartment fumigated multiple times and used promethazone cream with no relief of his symptoms. This also caused a great deal of financial strain due to multiple fumigations and urgent care visits. That's really a shame that he was misdiagnosed. And so I spoke with the patient, and he said he spent nearly $1,000 on fumigations and scabies treatments, and he never had scabies to begin with. He had an autoimmune disease, because that's what pleva is. It's an autoimmune disease. So I mean, it's really, that's really a shame that he had to spend all that money for something he never really had. All right. So the importance of this case lies in the possible link between the COVID-19 vaccination and the outbreak of the rash. Now, prior to his COVID-19 vaccination, the patient never had an outbreak of a rash like this before. Now, there have been case reports of pleva in the past with the COVID-19 vaccination. And I actually did a PubMed search and found about 13 case reports of pleva with the COVID-19 vaccination. And it was really interesting because it was like we'd see one case report, and then someone would reply to that with a letter to the editor saying, "Hey, we read this case report. This is what we found with one of our patients." And then someone would read that case report and say, "Hey, look, we read this case report. This is what we found with one of our patients." And so it was kind of this series of cases after case of people just reading one and responding back. So that's kind of interesting, you know? And so pleva should be considered a possible reaction to the COVID-19 vaccination. So the patient does, since his COVID-19 vaccination, the patient reports getting small outbreaks of the rash, kind of off and on. And he stated that they were not as severe as when he had his COVID-19 vaccination, and he had no fever, no chills, no joint pain. So basically, the patient had the acute form with the COVID-19 vaccination, and now he has the chronic form. So, I mean, it's too bad that he does, but, just the way it is. All right. So there's no good treatment for pleva. There you can use, I think I mentioned this before, you can use erythromycin or doxycycline, again for their anti-inflammatories, and oral prednisone for the acute form, and methotrexate has shown some promise for the chronic form. I think I mentioned the comment from I saw on the YouTube video about someone saying they had relief from it. Oh, and the reason there's a picture of this little baby that's sleeping is because the patient was informing me that he noticed he would get outbreaks of the rash whenever he would get about 3 to 4 hours of sleep. So I thought that was kind of interesting, and 3 to 4 hours of sleep, and then he gets the rash. Huh, you know, and that could be to multiple mechanisms. It could be immune dysfunction, um, or maybe just another inflammatory reaction. All right. So initially, the patient was misdiagnosed with scabies, and this caused a great deal of emotional and psychological stress. However, the patient reports a great deal of relief when he gets the rash now, because he knows the cause. He knows it's not something infectious like scabies, just an unsightly skin rash. And this really highlights the importance of getting the correct diagnosis. Okay, this is just a disclaimer. This should not discourage anyone from getting the COVID-19 vaccination. It's simply an unsightly skin rash that kind of goes away on its own, versus COVID can be lethal. And I spoke with the patient's dermatologist, and she agrees with this statement. And here are my references. So that's about it for me.